So everybody knows now Professor Mohty. So he's going to talk about optimal sequence of therapy at relapse. Thank you.
Good afternoon. Good morning, not yet. Actually, I do apologize in advance because you will probably be quite disappointed at the end of my talk, because it's likely that I will not solve the issue of sequencing. Also, at this time of the meeting, you already heard and have seen all the results and all the data. So I will simply share with you some parameters that we may need to think about sequencing. And actually, sequencing in terms of therapy in myeloma is not a minor issue. And the concept of sequencing is something that is a crucial step in the education of children. And we all started, these are among the basic learnings we start in our childhood, how to put things in a logical order, how to do things in a rational way in order to achieve a good results. These are my conflict of interest. And this is the reason why, if you surf and look, there are plenty of games trying to teach people and children how to sequence, because this is really a crucial step. So I don't know whether for us myeloma doctors at this level, how can we educate ourselves for doing this? I think at this stage, everybody now is convinced that the natural history of the myeloma disease has completely changed over the last 10 years, and now we are dealing with more and more relapses. And it is likely that the first and second relapse here are becoming a major component of the natural history of the disease. So in another word, it is extremely important, I believe, not to miss the maximum PFS you can expect from this spot. And this is why it becomes more crucial to try to find the right sequence between the initial therapy and the later therapies to optimize the duration of survival. So let us start first by defining when should relapse treatment be started. This is usually the $1 million question, because we don't have any biomarker or any objective parameter. We do have these biochemical relapses, and I have been always taught that it should not be too early but not too late. So what does that mean? It's a very subjective way of thinking. It's more related actually to the very close relationship between the physician and the doctor, where at the end of the day, after a certain time, you end up understanding the profile of your patient. And actually profiling people is a true science, and this is well used, in other fields. Then, of course, what we learned, you should treat when you have organ, let's say, damage. Also, these days, people want to start earlier and earlier, and this is why we discussed this morning about smoldering and high-risk myeloma. But even if we consider symptomatic relapse, are all symptoms equal? In another word, do we need to handle just simply anemia or bone pain the same way we handle medullary compression, hypercalcemia, or acute kidney failure? I don't think these are similar situations. The disease is very heterogeneous, and actually one of the difficult issues we are facing, we are always trying to find answer for one disease, while actually we are facing several diseases, and it's hopefully one day, soon I hope, myeloma will become like lymphoma, where we will be able to dissect, the different entities. Also, it's not only timing, it's also related to the factors to be considered. And actually, they are extremely broad whether related to patient-related factors, but also to disease or treatment-related factors. We just had a very nice talk about age, performance status, frailty, comorbidities, and we already realize how difficult it is and not straightforward, and there is a huge gap of knowledge until now. Bone marrow reserve, because we are hematologists, and I think we are always, I would say, proud of, acting on the bone marrow. If we don't see cytopenia, we're a bit worried about the drug we're using. But this is something that's not easy to quantify. And while we feel, the IMiDs have little side effects, the oral proteasome inhibitors have little side effects. But at the end of the day, if you accumulate this, especially in a patient who received auto transplant, I'm not speaking about double auto transplant, the cumulative amount of all of these treatments will probably amplify the issue of bone marrow reserve and its impact. Renal function, and we know that in myeloma, even when your number appears normal, we know these kidneys are very fragile and can decompensate very quickly. Pre-existing toxicity, and I think we discussed a lot about peripheral neuropathy. Quality of life considerations. Of course, we all like to speak about quality of life, but this is among the most complex parameters to evaluate, to assess, to understand, because quality of life of a guy who loves to play piano and who has peripheral neuropathy has nothing to do with the quality of life of someone who actually spends most of the time just watching TV with peripheral neuropathy. So it's and it's a cultural issue. There are cultures where, you need to hit the disease, you need to stay alive, it's quantity. That's more important than quality. And you go to other places where you tell I don't want quantity, I want really my best quality. So very, very complex parameters. I don't believe we will find rapidly an iPhone application to put all this together and solve the problem. We spoke about biology of the disease. And most of the data we have are actually from diagnosis. And we just extrapolate high-risk deletion 17p from diagnosis. But we also know that the disease is much more heterogeneous at the third or fourth relapse, and the clones are more resistant and so on. So actually, we are lacking some of these crucial data to guide treatment at time of relapse. They will come, they are ongoing, but they're not really ready. Initial therapy, it's a moving target all the time because, the paradigm is keep on changing. We have seen all of these drugs, and it's like, a huge competition to bring more and more combination. So it's becoming more and more difficult to handle this. Duration of initial therapy, and again, it's very difficult to find a true cutoff. Is it 6 months, 9 months? Is it going to be 1 year? We will hear later on from Muriel about, the issue of second salvage transplant. And we've been debating for 15 years whether you should perform a second salvage auto transplant, whether you do it after only 12 months of response, 18, 24. There are publications with 36 months. So again, the duration is very important because it actually reflects indirectly whether you're dealing with a so-called indolent or rapidly progressing disease. The efficacy of initial therapy is also a good parameter to consider. We know that we have patients who may relapse frequently, but they keep on being chemosensitive or so-called chemosensitive. On the other hand, you may have patients who from the beginning rarely do more than PR, but keep on smoldering PR. Every line you give, they have a minimal response, and you keep on giving more and more. Also, this will be modified when we assume, or if the field moves toward giving therapy, continuous therapy. Timing of relapse is going also to be an important issue. And this has to do with the issue of duration. And I think duration of the first remission is really the major factor to decide upon. It is a totally different story when you are trying to treat a relapse of a patient who received induction, auto-transplant, let's say consolidation, who's relapsing 5 years later, compared to this patient who is relapsing 1 year later. I believe these are totally different scenarios. The aggressiveness of the relapse is going to play a role, because if your disease progresses during treatment, it is likely that you're managing a more resistant disease. Otherwise, why the disease progressed under therapy? And it's likely that the resistant clone is already emerging. Early relapse, 6 months, probably alternative. These are really where there is an unmet need for these patients. And actually, for example, even with our modern induction therapy, if you look carefully, but we rarely speak about them because we are a little bit lost with these patients, you have 5 to 6 patients who are primary refractory. And we usually simply speak little about them because we don't know what to do with these patients. And then, of course, I mentioned late relapse. So, other considerations to consider for the sequencing. I believe that most of us now are convinced about the maximal response. And more, I think, the myeloma community should accept the idea of minimal residual disease. I mean, if you do lymphoma, everybody's looking for a negative PET scan. If you do CLL, everybody's looking for a negative MRD. It's only in myeloma where we continue the debate and we want more and more proofs. But I think this is becoming more and more obvious that you need to achieve your maximal response. But again, it has to be balanced based on the host. And again, coming back to the elderly, to the frailty, is it really a goal per se to reach negative MRD in a frail patient? So not very easy. However, I personally believe that the first remission, the first response, the early response is always the most important treatment period. And you have data already showing, especially when the patient becomes older and older, that the maximum quantity of life is actually gained or achieved during the first step of therapy. So, because we hear a lot of people saying, well, I need to keep my cards, I will use them progressively. Well, it depends, because sometimes if you're treating someone who's 75 years old, I'm not sure this gentleman or this lady will be able to receive treatment at age 90. So either you hit in an optimal fashion and try to achieve your 6 or 5 years of response, or probably you won't be able to reach the 5th or 6th line. So this is why I believe more and more, whatever step of the disease in the history, we need to consider what would be the most effective, of course, balancing against toxicity. And in my title, the proteasome, because we spoke about several issues, so I will go very quickly about the issue of proteasome, because we didn't discuss before with Michel, so there's some overlap, but there's no harm. The proteasome inhibitors are really a key component, and we have several candidates. Just to see how the sequence is important and how it's going to progress. First generation proteasome inhibitors, VRD, for example, is viewed today as the gold standard. And VRD plus transplant, this is the negative MRD. If you want to achieve negative MRD, you can see. So the question is, first generation proteasome inhibitors, lenalidomide, let's say it's the first generation of modern induction, how can we do better than VRD? And this is the idea behind why not carfilzomib? And this study, the CARTADEX study from Peter Sonneveld, has been mentioned several times already, where they have already shown that whether you consider high risk and standard risk, you are able, there was no MRD analysis, but I would assume that in this combination, KTD, there is a very significant and meaningful number of negative MRD. So the question is how to move forward, how to upgrade what we already, and it's important in the sequence, I believe. These are the survival data. One example, that was KTD, KRD. This is from Paul Richardson, showing very nicely the amount of MRD negative that you can achieve after a short induction. So the sequence between first generation, second generation, or switching can allow you to move things. In the relapse setting, we already have seen this slide several times, so I will go quickly on these. I would simply highlight that when considering sequencing, again, go back to this issue of high-risk cytogenetics. And it is likely that these novel proteasome inhibitors, second generation, are likely playing. Of course, we can argue about the issue whether, what is the definition of deletion 17p or whatever. But nevertheless, there is something coming there. Not necessarily overcoming, but still, you know, using second generation is likely more useful than first generation when it comes to salvaging these patients. Numbers lines of therapy, I'm not convinced that we are ready. We have enough strong data because the type of the line will change. Because it's not only in the analysis there was 1 line, 2 lines, 3 lines. But what is the components of the first line or the 2 lines? But it's important to consider these parameters. And this is like, I tried to put on the same slide, I adapted a slide from Mary V. Mateos with some other options, what we can see, all of these options. And how are we going to navigate there? It brings me back to the introduction, actually. This is the last slide. When you look, for example, to this, the profile of elotuzumab safety, age, performance status, frailty, it looks like the elotuzumab-based combination are relatively safe. But if, at the other hand, you have an aggressive relapse, the time to action of elotuzumab is very slow. So probably elotuzumab is not adapted as part of the sequence, and proteasome inhibitors are likely more attractive. Bone marrow reserve, everything that can induce cytopenia, IMiDs, you may wish to consider actually doublet if your bone marrow reserve has been already poor, or you have a poor marrow function, and this is where we heard the endeavor, you skip the IMiD. Renal function, here it's a different story. Proteasome inhibitors can be more attractive before switching, or we don't have the data, we don't have the data yet about the monoclonal antibodies in case what is the role in renal dysfunction. Pre-existing toxicities, if we don't have peripheral neuropathy, then maybe it allows you to reuse first generation bortezomib in case we have a long response to bortezomib. On the other hand, if there is a cardiovascular problem, there are cardiovascular problems in the host, it may be more problematic to use drugs like carfilzomib. Quality of life considerations, here again, I think in the sequence it's important to consider, because we always correlate oral drugs with good quality of life. I would like to have maybe a more slightly different opinion. I think it's important when we inform our patients, having an oral drug doesn't mean that it's 100% safe. These are active drugs. These are anti-tumor agents, and we need to be careful when it comes to oral. I'm not convinced 100% that giving oral drugs translate all the time with good quality of life. It's an important part of it, but I think we need to be more balanced. Sometimes having a systemic treatment coming to the hospital may prove interesting for some patients. I'm speaking about these isolated elderly patients. Sometimes coming to the hospital allows for some important checkup, for some social interactions, for management of other problems instead of, getting your oral drugs for 6 months without supervision. Compliance is also an important, and again, when it comes to our elderly patient, but it's the same actually in the youngest population. If we look to the CML example, it was amazing to see, this is a JCO publication from the Hammersmith, the proportion of patients who are not compliant. So I would be very curious to see if we monitor the compliance of our patients who are receiving, let's say, lenalidomide for 2 or 3 years, what would be the results compared to other, and I believe there would be some studies from Professor Nagler trying to assess this issue of compliance, because we assume they are taking the drugs, and I have faced several times patients who have more pills than expected, and then you don't know why they still have some stocks. Cytogenetics I mentioned, and component. With this, I thank you very much for your attention.
Thank you.